This is at the other end of the disease, not early disease, but the latest phases of prostate cancer, that is castration-resistant metastatic disease. The idea of this study was to look at the combination of atezolizumab and radium-223. Radium-223 is an FDA-approved alpha-emitting bone-seeking radiopharmaceutical that targets the primary reservoir metastatic disease, which is the bony compartment. And atezolizumab, of course, we know is a humanized anti-PD-L1 monoclonal antibody whose role in prostate cancer right now is investigational. The idea of combining these is that there's preclinical data and preclinical models that would suggest that one of the ways that radium works is by inducing an immune response in the disease that's localized near the deposition of the radium in bone. And the concept biologically was that you would then leverage that immune response with a anti-PD-L1 antibody, and then leverage that to accentuate that immune response and indeed perhaps enjoy a systemic benefit by virtue of the abscopal effect, so that that benefit wasn't seen just on a local level, but on a systemic level as well. So the trial was really a safety and feasibility study as a phase 1b study. The eligibility criteria were that men needed to have metastatic CRPC, progressing per prostate cancer working group 2 criteria, but they also did need to have measurable disease as well, because we wanted to be able to have a radiographic readout on these patients. Basically, the patients began in cohort 1 receiving concurrent dosing for a single dose with radium-223 and atezolizumab, and if that were tolerated, which it was, we would then explore 3 different arms, one with concurrent dosing where the radium and atezolizumab are given simultaneously, 2 where you would have staggered dosing where radium would precede the atezolizumab, and 3, the staggered dosing where the atezolizumab would precede the radium. So ultimately, the trial accrued 44 patients. Since the primary endpoint was safety and feasibility, I think the best way to discuss this is using that first. So we did see some of the IO-related side effects that have been seen in other disease types, and these included autoimmune hepatitis and myositis and other autoimmune phenomena. There were 2 grade 5 events that were associated with treatment-related AEs from the atezolizumab, so I think that's an important finding. There also were the usual adverse events that were related to radium that we know, so count declines, for example, were seen, and there was febrile neutropenia as well. In terms of response, which was a secondary endpoint, there were 3 patients of the 44 who did enjoy a pretty durable response. Those patients had a response of 192, 275, and 337 days, respectively. We did not see anything particularly specific to these patients or characteristic of these patients that we could predict who might respond in an enriched patient population later on. These patients represented both the concurrent arm as well as the staggered arm in which radium was given first. But I think that in terms of overall, what we saw was a typical patient population with metastatic CRPC who had a fair amount of treatment-related adverse events from each drug. But we didn't see enough responders with this regimen that we felt that the toxicity to efficacy ratio would be justified in proceeding. So although we saw some PSA declines, for example, these looked like typical radium-related PSA declines. We didn't see an amplification of the PSA decline rate by the addition of atezo. And although we did see these 3 patients who had really durable responses, it was unclear how we might identify those in the future and whether we might not have seen those effects with either of these drugs independently. I think that as we look to the future, how this might be further explored is the application of tumor-directed rather than bone-directed radiotherapy, which, since the field of tumor-directed radioligand therapy is really on the cusp of exploding. This is a strategy of combining that therapy with immunotherapy in the future that I think is worth exploring, even if we don't use it, do that exploration with the specific combination of radium, which is bone-directed radiotherapy, and atezolizumab.